The second universal definition of myocardial infarction introduced 5 different types of myocardial infarction. This was refined even further by the time they hit the third international definition of myocardial infarction. We're talking about one of them today that doesn't get a whole lot of respect for some reason. It's looking at supply-demand type 2 myocardial infarction. Should we be paying more attention? And this is from JACC. It's online before print. Can't tell you the exact issue it'll be in. Look at the end of the video. The citation should be there. And I'm with Dr. JADR Sandoval, who is an MD and a CV fellow at the Hennepin County Medical Center in Minneapolis. In your paper, you note that there is this controversy, this kind of reluctance to use the term. Why, I guess, is my first question, and then we can talk about why it's important.
Yes, absolutely, Rick. Thank you, first of all, for inviting me to expand a little bit on this topic. First of all, I think this is a very important topic. It's probably one of the most clinically relevant challenges in contemporary clinical cardiology. And this is a problem that has come up to us, probably related to our improved ability to detect ischemia. So in other words, because we have better troponin assays, and in the near future in the United States, probably the approval of high sensitivity troponin assays, now we're detecting different causes of ischemia, as you know. So now in both the research arena as well as in the clinical arena, we're, cardiologists, emergency physicians, everybody's encounter with patients in which we have to detect is this troponin elevation above the 99th percentile related to an ischemic event or a non-ischemic event. And it's related to ischemic. Is this plaque rupture or is it supply-demand? Right. And that's where the problem comes. What is supply-demand? As you mentioned, in 2007, this type 2 MI was originally introduced, and it talked about the pathophysiology of supply-demand imbalances, but no real detailed definition of what specifically it consists of was offered. And for that reason, in our paper, what we do is it's a viewpoint paper, and whenever people look at our main table 1, it goes in details over all the literature and research that has been done on this entity of type 2 MI. And what you see is that there's this inconsistency on how researchers and clinicians are defining this entity.
That's not good.
Right.
We prefer consistency when we're dealing with cardiology.
Yes. And that's the main reason. For example, you see the prevalence and the percentages of type 2 in each hospital and in each study, it's quite different. It can go from 20 to 40 to 60, 70%. And it's, for example, because we have different criteria of how we're defining this entity. So it's actually important both, again, clinically and research-wise, because in the clinical field, we do not know how we're defining this, but more importantly, in the research basis and to go into the future, it's unclear what consists type 2, and that's what we really go into detail in this paper.
In terms of just general advice, if you're going to be dealing with patients and you think it's a supply-demand issue, how does that affect any decisions that you're making?
Yes. That's a great question. So this is one of our other very important things that we emphasize in the paper, and it's one of the good things of the universal definition of MI is that patients that have type 1, the plaque rupture myocardial infarction, we know that those are the patients that we usually give antiplatelet therapies, they go to the cath lab, and so on. But in type 2, we don't really have a good algorithm to follow. And nowadays in clinical cardiology, it's essentially you try to correct the underlying etiology of what you think it's causing the supply-demand imbalances, but that's actually the importance of trying to differentiate these entities because management completely differs. And since the definition is not clear, probably type 2 MI patients, you want to make sure that you're truly certain that it's type 2 and not type 1 before you give these patients antiplatelet therapies and that increase their risk. With giving these therapies that they probably shouldn't get. So that's actually a very important issue that you raise.
How long does it take to know whether it's a supply-demand type 2 problem?
I think that's very variable. And one of the things that we mentioned in our paper is that, there's very interesting populations with supply-demand. They're different. There are some folks that walk into the emergency department and they're able to provide a good history. So history is going to be very critical. But there's another subset of patients that determining if they have supply-demand or type 1 is very difficult. And these are, for example, in the perioperative setting, where patients are, they have anesthesia going on, they might not be able to rely their symptoms. And another important setting is also in the intensive care unit, where patients might be intubated. So in these patients, you'll see troponins above the 99th percentile, you see ECG changes, you might see well motion abnormalities, and it's very difficult to discern what's the etiology. So I don't know that there's a time frame to figure out which one it is.
But it's important to do it.
But it's very important to do it because therapy will change. Another important thing related to this that we also really make some comments on our paper is prognosis. I was going
to say outcomes. Do we know anything regarding that?
Yes, so there's emerging data that is probably showing that type 2 has either similar or even worse outcomes than type 1 plaque rupture pathophysiology events. This data, it's retrospective, so sometimes difficult to control for all the different variables, but there appears to be an ongoing emergence of different data that has suggested that, in fact, just recently the Savvy et al. And Thigesen from the Universal Definition of MI, they have come with some data suggesting that even controlling for different variables, type 2 MI might have a worse prognosis. That's one of the very important reasons I think the cardiology community has to pay more attention to this entity.
Right.
Because for type 1 or so-called acute coronary syndrome, you go online and you have guidelines for NSTEMI, guidelines for STEMI, you have algorithms for all providers, and you have your cards.
Yep.
So we have a very detailed approach to what to do for patients that have type 1 acute coronary syndromes. Whereas in contrast, in type 2 MI, we have no guidance. We don't know what to do. It's quite variable. You can see physician A, B, and C, and management, it's quite variable. So I think we really, because of this probable worse prognosis and lack of definition, we really need to be paying more attention. I think this is probably one of the next frontiers in contemporary clinical cardiology, where we should be paying more attention.
What percentage of patients end up with type 2?
2 or 3 different variables. One of them, it's the assay that you're using. So depending on how good your test is, you would be able to have different abilities to detect ischemia. So for example, one of the concerns is that we do not know how high sensitivity troponins will affect the percentages of...
I was just talking to Dr. Mahaffey about that afterwards. Yeah, this is going to bring all kinds of headaches once that happens.
Yes. So I think it's going to be a great area for research and to try to understand how this is going to affect the incidence of type 2 MI. So one thing is the assay. I think the other thing is the tested population. That's another thing that we really talked about in our paper, and is should we be testing the folks that come and really have like a real good ischemic history of chest pain, or should we also be testing these folks that I was saying like in the ICU? It's unclear who should we be testing, and depending on who we test, also our incidence of type 2 MI varies a little bit. So I think those are 2 important variables that will really change the incidence of type 2 MI. And the other thing related to the definition is how we define it. Right. So if you look at some of the studies that we go in table 1 in our paper once it's out, the study is that, for example, they will extract their patients of type 2 MI from trials that were acute coronary syndrome studies. And you'll see that their type 2 MI prevalence was very, very low. But it was an acute coronary syndrome trial. They were not really looking for it. Right. And then you look at other studies that they were looking retrospectively at all patients that had a troponin above the 99th percentile, and type 2 is much higher. So the study population also will play a role in how much type 2 MI you will encounter in your practice.
Well, Dr. Sandoval's paper is coming out in JACC. It's online before print. Please look at the end of the video because that'll have the citation for you. This is an important topic, and it is a really good paper from the Journal of the American College of Cardiology and from CardioSource World News. I'm Executive Editor Rick McGuire.